at the case studies. Thank you very much.
Thank you. Simon Furr.
Thank you, Chair. If I can just follow on from Stuart McDonald's point there, I've got a fantastic treatment and rehabilitation centre in my constituency. They operate in Cumbria and North Lancashire, called the Well Communities, and they're great, but they are very locally focused. And just interested to hear your views on whether you think there could be a one-size-fits-all solution based on the wealth of evidence and case studies you've got, if properly funded, or whether you think these things are better to grow organically in the communities that they serve. Perhaps if I come to you, Councillor Harding, first.
I think I referenced in an earlier response that I don't ever think there's a one-size-fits-all, and certainly in Cumbria you've got huge rural communities, haven't you? So your access to treatment is going to be different, transport links for people to get to treatment, your demographics may be different, though I know there are, again, huge areas of deprivation and poverty in Cumbria too. So I'm not necessarily saying that a one-size-fits-all. I do think that we should adapt and grow some of those very old-fashioned traditional systems that we had around drug treatment services way back when aren't the services that we want now. We want them to be more responsive, more flexible to people's different needs. So I think communities should develop and grow them. And as I mentioned before, with some co-production in that as well, how do you bring people together to say, we shouldn't be being prescriptive in a way that we tell people what they should have. We should develop it with them so that we get the right fit for that particular community.
Minded to agree. Just wondering if any of the other witnesses have a view. So, Ms. Boreham.
I think if we go back to the Black Report, which is incredibly helpful, it talks about a recovery-orientated system of care, and this is really kind of made up of a number of different. It's both voluntary and statutory, and and it needs to be co-created with peers, with people with lived experience. So, for instance, we're looking at recovery housing at the minute, but some of that recovery housing will be delivered by, or likely to be delivered by, local organisations who have a particular interest in working in particular communities, which is because we know that in actual fact particular communities, say for instance older black men are not really being seen in our treatment systems in the same way that we would, but for some reason there's a barrier to that. So we now have an organisation that delivers particular, kind of a pathway into treatment and is looking at developing recovery houses. And we would want to deliver, I think this is it. You need to have a number of different options that are very much relating to your local population.
Thank you. And Professor McManus, do you have anything to add to that?
I'd echo what my colleagues have said. We know that one-size-fits-all approaches work for very few things, and I'm a trustee of a hospice outside work, and it doesn't work in palliative care, it doesn't work here. If you take the Black Report's thread, as Maggie has said, of recovery-oriented treatment, the best thing to do is get local partnerships to fulfil their statutory duty of really assessing and understanding the needs of their population and building a plan based on that need, which will be different in Cumbria than it is in somewhere like Brighton because of geography, for one thing, and really respond. The acid test is whether they're really understanding and co-producing with their community a footprint of services that actually works for that community. So it's, I think, outcomes, not portfolios of services, are the crucial acid test, I would suggest.
Thank you. That's really helpful. And if I can just ask one more question. So in the Scottish Parliament, a bill was introduced which was trying to enshrine a right of recovery for individuals who are dependent on drugs, effectively giving them the right to request a range of treatments. Would you support a bill like that?
Yes, definitely. I mean, there is, for UK citizens who are usually resident within the UK, they already have rights to medical treatment, which is under the Human Rights Act and the Public Sector Equality Duty. However, I do think that the Scottish Parliament is quite right to take that forward and further develop it and make sure that there is a right to treatment which includes access to evidence-based treatments, a range of evidence-based treatments, and also doesn't interfere with the relationship and the clinical decisions that are being made between the clinician and the patient or the service user, so that that those clinical decisions are respected. And I think we probably should, kind of have a UK-wide adoption of the Scottish Drug Deaths Task Force minimum standards for medication-assisted treatment.
Thank you. It has been suggested that some of the existing powers in law already provide this right. So, to your mind, what's the uplift that you would get from this, or the clarity that would be given?
I think I'm certainly not an expert on this, but what I would say is probably the difference is that we're able to kind of make sure that it does allow a full range of access to evidence-based treatments. Whether that's kind of the different harm reduction, heroin-assisted treatment, for instance, but also that there isn't the law doesn't interfere in the relationship and the clinical decision-making that is taking place between the person in treatment and the clinicians and the recovery workers that are working and collaborating with that person in treatment.
Thank you. And Councillor Harding, do you have anything to add on that?
I think from an LGA point of view, we are obviously committed to the 10-year drug strategy, and that people get the right treatment in the right place at the right time. Insofar as enshrining in law, we know that the wait times for treatment is actually reduced. People are getting the treatment that they need. They're not waiting a long time to access treatment. More importantly, it's about those wraparound treatments that people need, those other community treatments. So the LGA stance is that really we would need to see more evidence that enshrining something in law genuinely does improve outcomes for people.
Thank you. And Professor McManus?
I agree with my colleagues. I think the key thing about the Carol Black review was it was a wake-up call for central government, because local authorities have known since we took over commissioning of drug and alcohol treatment how important it was, but there hasn't been the funding. A wake-up call by a right enshrined in law would be good, because the rights in the NHS Constitution don't go far enough, in England anyway, to safeguard people's rights to drug and alcohol treatment. So a justiciable right in statute should be welcomed, provided there is a sustainable funding to deliver a really good treatment service. So if the money's there, a right works. If the money isn't there, I think a right might fail people.
Thank you. And you've led me to my next question, which was going to be, if this did become law, what would the impact be to delivering it for you, I guess, at the front line?
Well, I guess if the money was there, the impact would be that we could really have a system that enabled people who have problems with drugs to absolutely thrive and contribute to our society economy in the way that they want to and live the lives they do want to. That's the vision that Dame Carol Black, I think, holds out to us: recovery-focused treatment. The worst case scenario is that you have a whole load of people who can't get access to drugs because the money isn't there to fund them, suing the Secretary of State and suing local authorities, and money that should go into treatment is paying lawyers.
And just for the avoidance of doubt, that money is not there at the moment. So whatever is to be enshrined in law, you could not deliver on it as it's going.
Yeah, there is more money, really welcome more money, but there isn't enough money to deliver heroin-assisted treatment. There isn't enough money for overdose centres. We need sustained and more investment, because the money we've got doesn't make up for the money that was cut significantly over several years from the public health grant and from the Drug and Alcohol Treatment Centre. It's great, it's wonderful, but it doesn't make up for what we've lost.
Thank you.
Thank you. And that's very helpful. Can I just ask